learn about ostomy. I know we all are nurses. We all know what is ostomy care. How we can take care of our ostomy patients. But in palliative care, let's see what else we can uh, add for better patient care. So let me share my screen. I hope my screen is visible to everyone. Is it visible? Yes. Okay.
Yes.
Thank you. So, in types of ostomies, there are input ostomies and output ostomies. Input ostomies, tracheostomy, gastrostomy, feeding jejunostomy. Output ostomy, colostomy, urostomy, and ileostomy. So these are the type of ostomies. So before moving on to the session, I would like to go with the patient story. Mr. Raman is 35-year-old gentleman. He was diagnosed to have carcinoma colon 2 months ago. He underwent protocolectomy and ileostomy followed by chemotherapy. He has now come to your OP accompanied by his wife with skin excoriation around the ostomy site. He looks tired, agitated, with poor skin turgor. His wife says after the surgery he is angry and upset. So my question is, what could the problem? So what could have contributed to him developing skin excoriations? So what is the cause of developing skin excoriation to this patient? And the next question is, why is he angry and upset? I hope this patient story is clear to everyone. Please put your answers in the chat box or you can unmute yourself and talk. Stoma leak and poor skin care. Okay. Excoriation could be due to moisture, poor ileostomy care. Okay. Anything else? This patient is having ileostomy.
He is having so many tubes, so discomfort.
Only one tube is there. Only one ileostomy.
Ileostomy and colostomy? No.
No, only ileostomy.
Okay. And plus he had a chemo, so that also will make him tired and agitated.
Okay, very good.
The patient age is only 35, ma'am. She can't do our day-to-day activities because of that. Ileostomy tube is disturbing him.
Okay, yeah. So maybe before surgery, he was thinking like, okay, after the surgery, everything will be okay. But after the surgery, he realized that whenever the bowel moves, the fecal matter will come out. So that will not be able to manage because maybe because of that, he has developed some psychosocial issues because they may be emotional problems also. He was not able to accept the truth. That kind of situation is also there sometimes. Okay, maybe because of that, he might be angry and upset. Any other answers? So we know whenever the bowel moves, the fecal matter will move, right? So for a normal person, when the bowel moves, that fecal matter, the stool, formed stool will be collecting into the rectum. When the rectum is filled, then the message will be passing to the brain, and then the brain received a signal, and we will go to the toilet, and then we will do the defecation, no, right? This is the normal process. But here what happened, the ileum, if the patient is having any problem, any tumor in the intestine, if for example the large intestine, if the large intestine has developed any tumor, so they usually do ileostomy. So here what we need to understand is, when the ileum move, the small intestine moves, the fecal matter will come out. The leaky watery stool, watery stool will come out, right? So that may be because that is the major cause of developing skin excoriation here. So here let's see the parts of small intestine. We know there are three parts of small intestine: duodenum, jejunum, and ileum. Ileum is the last part of the small intestine. What are the functions of small intestine? So if there is any problem developing into the small intestine, these all problems, these all functions will be affected. So receive, the first function is receive digestive enzymes from the pancreas and liver. And the second function is break down food with digestive enzyme, make it more digestible. And the third one is absorb nutrients, including fats, carbohydrate, protein, vitamins, and minerals into the bloodstream. So the most of the nutrition and the absorption will be happening into the small intestine. And then help to for that, because of that, we can able to maintain the fluid balance. Okay, the absorption of electrolytes is also there in the small intestine, mostly in the large intestine, but few things will be happening into the small intestine also. After that, move the food along to the colon, and then again one more function is help to fight disease causing bacteria ingested with food, mobilizing the body immune system. So these are the functions of small intestine. Just imagine if there is any problem developing into the small intestine, these all functions will be affecting. Okay, so these you have to keep it in mind all the time. What happened into the ileostomy? So what you have do in ileostomy is the surgeon will pull out the ileum into the abdominal valve and stitch it over there. So when the small intestine, the peristaltic movement occur, the fecal matter will come out. The watery stool will come out, because most of the sodium and water absorption will be happening into the large intestine. Before that, the fecal matter will come out. So it could be, it's around 500 to 1300 ml, and maybe up to 1800 ml of output will be happening in every day. And because of their poor electrolyte absorption, the patients will be developing electrolyte imbalance, because before reaching into the large intestine, the fecal matter will come out, right? So because of that, the patients might have developed electrolyte imbalance. And the third one is higher concentration of digestive enzymes in that fecal matter. So that fecal matter will touch the normal skin. that leads to the patients can develop skin excoriation. So this patient was having ileostomy. Maybe this could be the cause of developing skin excoriation for this patient. Okay. And excessive water loss. Through the ileostomy, excessive water loss will be there. And then risk of developing dehydration and renal stone. So these are the things happening when the patient is underwent ileostomy. Okay. Coming to the stoma. Stoma is an artificial opening. It is an opening that connects to the body cavity to the outside environment. That is called stoma. Just see, this is stoma. Just you can pull out the intestine out and you can stitch it on the outside so that the stoma will be opening all the time. There is no sphincter in our in our anus. We have a anal sphincter. We can able to control the fecal matter unless diarrhea. So if the sphincter is not there, what happened? The fecal matter will be passing all the time. Just imagine a diarrhea, frequent diarrhea. We cannot control sometimes. So here also the stoma will be opening all the times so that the fecal matter will come out. And if there is a stoma there, we can fix a bag into the stoma so that the fecal matter will be collecting into the bag. Right? So, as I mentioned earlier, whenever the bowel is moved, the fecal matter will come out. There is no control. Okay, so you have to keep fix a colostomy bag onto the stoma so that we can able to collect the fecal matter into the bag. So coming to the colostomy, we know in our large intestine 4 parts: ascending colon, transverse colon, descending colon, and sigmoid colon. Okay, so here you can see the colon. Wherever the tumor is developed depends upon the tumor place. So the surgeon will decide which colostomy has done for that particular patient. For example, if the patient is developing a tumor into the transverse colon, the fecal matter will not move out from the ascending colon to the transverse colon because there is a tumor. So then the surgeon will decide we have to do the ascending colostomy because there is no way to move the fecal matter from the ascending colon to the transverse colon. There is a block. Clear? Then ascending colostomy we will do. Then if there is a the descending colon tumor there, then the surgeon will decide, okay, we can do transverse colostomy. Depends upon the tumor site, the surgeon will decide the colostomy and do the colostomy. So understand the nature of output will be different in different colostomies. And the problems also different in different colostomies. And the management is also different. So these are the 3 important points you have to keep it in mind. Coming into the colostomy. Colostomy is an opening created into the body to allow removal of fecal matter from the large bowel or colon. You can see when we do colostomy into the sigmoid colon, there will be an opening. So through that, the fecal matter will come out. You can fix a bag onto that stoma, then you can collect the fecal matter. Here, these are the parts of intestine. One, ascending colon. When the fecal matter coming from the ileum to the ascending colon. So the type of fecal matter into the ileum is watery. That fecal matter will be coming into the ascending colon. Then the output is again liquid and acidic, right? The small absorption will be happening into the ascending colon. Small absorption will be happening into the ascending colon. Then the fecal matter will move from the ascending colon to the transverse colon. Again, liquid and semi-formed. After a few absorption happening into the ascending colon, then the fecal matter will be in semi-formed, liquid to semi-formed stool. So here also unpredictable output. We can't predict. So some loose stool will be coming out. And coming to the descending colon, colostomy, mostly semi-formed to completely formed stool will be there because ascending colon and transverse colon will be absorbing most of the water from the stool. So most of the water, mostly the water will be absorption was done in the ascending colon and transverse colon. Then it will be maybe more the semi-formed and completely formed stool will be there. So coming to the sigmoid colostomy, the stool is completely formed because the stool will be passing from ascending colon, transverse colon, and descending colon. So that all water absorption has done from that three parts, and then finally the stool, the formed stool will be there in the sigmoid colostomy. So that time we can able to predict. Mostly we can able to predict after the taking food through mouth. It's around 6 to 8 hours, the bowel become free. So the formed stool will be there in the sigmoid colon will be around after 6 to 8 hours. So what are the problems faced by the patient with the stoma? One is peristomal skin reaction. It could be mechanical, it could be chemical, it could be microbiological. So when a patient comes to you with a peristomal skin reaction, it's our duty to identify the cause. So it could be chemical, maybe because of the material. It could be mechanical, maybe because of the mismanagement of maybe not no that no the nurse is not having a good skill to take care of a colostomy patient, so that the nurse will remove the ostomy the wafer from the ostomy area without supporting the abdomen, so that there is a chance of mechanical injury. So there is a mechanical skin. After that, the patients can develop skin excoriation. Then it could be a microbiological because of the wet, and also the patients can develop fungal infection. So microbiological is also happen. And the second problem is stoma prolapse. So the slight stoma, if there is a prolapse more than 5 centimeters, then you can send the patient to the surgeon. So less than 5 centimeters, then you can do what you can do is you can lubricate your little finger and with the silocaine jelly, and ask the patient to take a deep breath, and then you can you can try to insert the colon into the abdomen. So after that, what you have to tell the patient is, whenever they cough, if they want to sneeze, so they need to support the stoma. They need to support the stoma so that the stomal prolapse we can prevent. And the next one is stomal retractions. You can see, so if there is a stomal retraction there, we can't fix the bag. There is a stomal leakage. Through that, the side of the stomal region, through that there is a chance of fecal matter leakage. So stomal retraction is also another problem. Then you can use convex pouch system. Convex pouch system. See, this kind of material, the colostomy bag is available. You can use convex pouch system. And then the next one is stomal stenosis. Stomal stenosis is narrowing your stoma. So we are not able, because if there is a narrowing, there is a stomal stenosis develop, the fecal matter will not be able to come out. Then the patients can develop cramping like pain, cramps, abdominal cramps. So what you can do is you have to refer the patient to the oncologist or surgeon. So that is the immediate action you have to be done for this patient. So surgical correction is needed. And another problem is constipation. So inadequate water intake is also another problem. And so inactive stoma, 4 to 6 hours so within 4 to 6 hours, the bowel need to move. So after, if the bowel is not moved uh, after 4 hours, then you can think about the medical attention, refer the patient to the oncologist and see there is any intestinal obstruction or anything. So that is also important. And also you have to think about the stimulant laxatives, because sometimes this kind of patient, this type of patient is taking morphine also. So one of the most common side effect of morphine is constipation. So we have to avoid. So if you prescribe morphine, at the same time you have to give some stimulant laxatives also. So for these also you have to keep it in mind. So we have a video on colostomy care. I'll show you now and then I'll teach the remaining part. Thank you. I hope this video is clear to everyone. So these are some colostomy appliances. There are one-piece method and two-piece methods is available. You have seen the two-piece method. How we apply, how we fix a new wafer onto the stoma, or how to remove a colostomy bag from the wafer and fix a new one. And changing the pouch and skin barrier. So also you have seen in the video avoid mechanical injuries. Always you have to protect the skin. You have to push the skin gently, and then you have to try to remove the stomal wafer from the stomal area. And if there is any adherence there, what you can do is you have to take a warm water and then that put some warm water into that area, so that resistance will reduce, and then you can able to remove it easily. So always you have to pat and dry the area. Okay, so and the next thing is changing the pouch and skin barrier. While applying skin barrier, the circumference of the stoma, that also should be correct, because we have the stomal that slide guide is there, so that you can able to take a measurement to the stoma, from the stoma. Then you after that what you can do is you can take a measurement that like for if you take 30, if you get 34 mm into that measuring guide, then you can same thing you can do it on the back side of the wafer. There is a marking there, then just larger than the correct size. So if you get 34 mm, then you can cut it in 37 or 39, because if the opening is too small, it will be the irritating the stoma, and that leads to bleeding. If the opening is too big, that leads to leakage. So it should be correct size. Okay. Then you can cut it like this, and then you can remove the protective layer from the that area, that wafer, and then you can fix it. So from the video, you have seen this. Okay. And coming to the colostomy diet, there are no absolute dietary restriction here. If there is any bad smell, malodor, then you can what you can suggest is you can educate them to control their that garlic, cabbage, onion, these kind of foods. This will create smell. So these kind of foods they can control. Okay, not stop, no need to stop, you can tell them to control. And so here also from the ileostomy you can expect after eating, you can expect after 2 hours, any time that matter, that digested fecal matter will come out. And for the distal colostomy, it's around 6 to 8 hours. Okay. And corn, nuts, cabbage, these kind of things will hardening the stool. So if someone's complaining of constipation, then you can think about this also. Again, if they better, they can use a same oil for cooking so that we can able to prevent diarrhea. And another important thing, if there is a entry quarter tablet there, it will not work because that fecal matter will come out. So that will be that worked in the that colon only. So it's that time only that action will be there. No, if there is ileostomy the patient there, that your that medications will not help. And travel, work, and sports, there is no restriction because they can travel like any other persons, but they should carry extra bags, and also they should take a purse like things because the other traveler doesn't know whether the patient is having colostomy or not. So when they travel, they have to protect the stoma with the help of a purse, right? So that that colostomy, the stoma will not affect anything. And also you have to educate the patient to not take heavy lifting, strenuous exercise like that, and avoid contact sports like kabaddi, that kind of things they should avoid. But otherwise, that small activities and involvement is doesn't cause any problem. So this is your next case scenario. Mr. T, 45-year, was diagnosed with carcinoma rectum and had undergone epiresection and sigmoid colostomy 3 months ago. He has been using disposable colostomy bag for bowel emptying. He is a management executive and find it very difficult to manage it. What option can you advise him as a palliative care nurse? Any suggestions? The patient is sitting in front of you and complaining that I am not able to manage this colostomy bags. Is there any other option? I need to continue my work because I am the breadwinner of the family. I need to continue my work, but this colostomy bag is not able to manage in the office time, especially. So is there any suggestion? Any other options? Tell me, tell me. Patient is sitting in front of you. You have to tell something.
Ma'am, does it is a sigmoid colostomy, so can the bowel habit, the making one time bowel habit like for him, and then he can wear the loose cloth little,
Loose?
means loosen up clothes like not too tight, which because he's executive, so he's going for the work job.
Yeah, he actually that is not a problem. He used to wear loose clothes after the surgery, but the
Ah.
problem is he is not able to manage the colostomy bag because whenever the bowel moves, the fecal matter will come out, right? So he needs to go to the toilet in between his works and need to discard the fecal matter and fix a new bag and come back to the work and then so this is not able to. This is the problem. He is asking you to because if you any is there any other option? That is the main question. Okay, we should explain the in detail and he should carry extra bag. Yeah, he has a lot of extra bags, but the thing is no need to, no way to remove it and discard the fecal matter and all. That is the problem. Training, counseling. Okay, then
Ma'am, colostomy closure is there now, no? Like
colostomy.
any closure means
Closure means
actually the patient stoma will be closed, ma'am. Any
uh,
procedure?
we can't close because this patient
Okay.
is having clear rectum. If we
Okay,
close
okay.
the stoma,
We
where that
can't pass the motion.
yeah, he needs to pass the motion, no? So there is no way to come out the fecal matter. So the thing is, you bigger size colostomy bags. Okay, if you okay bigger size colostomy bag, then because of the weight, the wafer will come out. Because of the fecal matter weight, the wafer will come out. No. So that is not an option. So what you can do is you can suggest colostomy irrigation. I don't know how many of you know this colostomy irrigation. This patient is having sigmoid. This patient is having uh, sigmoid colostomy, right? Sigmoid colostomy. What is the that fecal matter in the sigmoid colostomy?
It is full
What is
form, ma'am.
we got the type of fecal matter in the sigmoid colostomy is formed stool, completely formed stool. So, like an enema, you can irrigate the bowel. Okay, irrigate. You can irrigate the bowel. So, what you can do is you have to see if someone has agreed the colostomy irrigation, you have to that educate them. What are the purpose? So if he is in front of you and asking you, is there any other option? Then you can tell there are options. This colostomy irrigation is there, but these are the purpose. So if you do colostomy irrigation, you can able to establish regular bowel habit. So that all when you do the colostomy irrigation, then all fecal matter will wash out. And then so that after washout there is no fecal matter because after that 6 to 8 hours the bowel will be free, the bowel movements will be there is no fecal matter, so that we can able to prevent skin escoration. Clear? Okay, so you can use plain lukewarm water, plain lukewarm water, not cold water. If you take too cold water, what happened is if you introduce into the colon, so that the colon will start colicky pain. If it is too hot, what happened? The stomal burns will be there because that mucus will membrane will be affected because of too hot. Inflammation will be there. So it could be it should be in the plain lukewarm water you can take. So you can take 1 to 1.5 liter at a time, and then you can irrigate. You can introduce that water into the colon and wait for the return flow. I have a video on that. I'll show you. So these are the 3 instructions you have to given to the patient. Because if someone agree with the colostomy irrigation, you have to tell them you have to be do is a lifelong. This is a lifelong procedure. This is not an on-time procedure. every day morning they have to irrigate so that the bubble habit will form. And within 21 days, the bubble habit will, if they do it correct, that properly, definitely the habit formation will be there in within 21 days. So actually, 3 months after surgery, we can do colostomy irrigation. But nowadays, the literature said like 6 weeks after surgery also we can do colostomy irrigation. So if you do the colostomy irrigation, what you can think is, if a patient comes to you with the sigmoid that colostomy, so the fecal matter will be formed there, and then you can suggest colostomy irrigation. If they do colostomy irrigation, after when the fecal matter will come out, the whole fecal matter will wash off from the colon. So after that, the 6 to 8 hours, the fecal matter, the bowel will be free, so that the persons can go anywhere. So during the office time, his bowel will be the bowel movement will be there. There is no fecal matter. He can that apply. He can just fix a colostomy bag on the stomach, but nothing will come out. Clear? So we can watch that video and come back. Colostomy irrigation. Everyone, any doubts? Any doubts? So I have a patient. So this is one of the best method for a sigmoid colostomy patient. So I have a patient since last 10 years. She is doing colostomy irrigation. I met with her last uh, Tuesday. So she was very happy, and she was managing very well. So after the irrigation, she is very happy to move anywhere, because she used to travel different places, but she is happy. So she actually in 2013, I taught her about this colostomy irrigation. After that, she developed some colicky pain, and then the colicky pain that resolved, and then she can able to manage independently. So if when we start irrigation, sometimes the colicky pain will start. What you can do is, you can stop irrigation for some time and wait for another 2 minutes, so that all colicky pain will subside, and then you can restart the irrigation. So the idea behind this colostomy irrigation is, once you irrigate the bowel will be colon will be free after 6 to 8 hours. Okay. So I think, yeah. Can colostomy patient do swimming? They can do swimming, but not heavy. But they can do. They can protect they can cover the colostomy area with a towel or something like that. They can tight that area, and then they can do swimming. But the thing is not in theoretically it is not that advisable. But if they want to swim, you can encourage. Okay, so we can move on to the next part. Now we are going to learn about input ostomy, that is tracheostomy. So tracheostomy, we all know that tracheostomy is an artificial opening made into the trachea, in which a tube is inserted to establish and maintain a patterned airway. So if there is any upper part obstruction, like CA esophagus, there is no chance to go air into the lung, so there is an obstruction. So that time we used that surgeon we usually to do a tracheostomy. So this is the input ostomy, so that if you do a tracheostomy, through that tracheostomy, the lung will get enough oxygen. So right, there are tracheostomy. If you do a tracheostomy, we usually put two tubes, inner tube and outer tubes. The three parts are there in the tracheostomy tube: inner tube, outer tube, inner tube, and obturator. So outer tube remains in place by with the we used to tie the outer tube with the help of a ribbon, and inner tube which will be fixed in inside of the outer tube, that we can able to remove it and wash wash out the that mucus or sputum inside the inner tube, and then you can replace back. And obturate, the purpose of obturator is to guide the outer tube into the while inserting into the trachea. For the first insertion, we need a obturator, so that surgeon can easily insert a tracheostomy tube into the trachea. So for the inner tube part, we have to train the patient about inner tube cleaning. With the help of a mirror, they can do it. Okay, with the help of, they can see, they can fix a mirror in front of them, and they can see that tracheostomy into the mirror, and then they can remove the inner tube without that support anyone. So because in between they need to remove the inner tube and clean it. So without depend others, they can do it. And so there are different types of the tracheostomy tubes are available: portex tube and metal tubes. If there is a portex tube there, then you can take out the inner tube from the outer tube and clean under running water, and clean with normal saline, and tap the water from the inner tube, and you can insert the inner tube into the outer tube. For if you are using metal tube, you have to boil it. Take out the inner tube from the outer tube and wash the inner tube under running water, so that all the sputum and mucus will go down because the force of water, so that all this will be in the inside of the trachea, no? So there is a chance of sputum accumulation, cough. If there will be a sputum accumulation there, mucus will be there. So we need to remove it. Always when we see the inner tube, you can fix the inner tube into the outer tube. The inner tube length is more than the outer tube. The reason behind the inner tube is length is more is if the inner tube length is too short, the outer tube will block because of the sputum, because of the secretion. So the inner tube is longer than the outer tube. Okay, so we need to remove the inner tube and clean under running water, and boil it, and we have to replace back within 5 to 10 minutes. Otherwise, there is a chance of blockage of outer tube. And outer tube changing of type. So that is also the one important part is advisable, but the self attempt is not advisable. Okay, so if they want to change the tie, if the tie is dirt, definitely we need to change. But maybe one of the nurse or doctor can fix a outer tube, because if you touch the tracheostomy tube, the patient will start cough, right? So that there is a chance of the outer tube will come out. So what you can do is you have to fix a new tie first, and then try to remove the old tie. Clear? You have to fix a new tie first and then remove the old tie. Otherwise, there is a chance of fall down of outer tube from the the trachea because of there is a very sensitive area. If you touch the tracheostomy tube, the patients will start cough. And coming to the skincare, again, that around the stoma is very important care needed because there is that metal tube. Usually, after Portex tube, if there is a permanent tracheostomy there, we used to do the surgeon used to do fix a metal tube. If they have a metal tracheostomy tube, there is a chance of that stomal erosion. So we have to check the area and keep the skin that clean and dry, and put a Vaseline gauze around the tracheostomy stoma so that we can able to prevent excoriation. And suction and humidification. So for the suctioning, you can do suctioning, but in palliative care, we can't, we don't encourage much suction. But if there is any secretions, more secretion there, then you can do suction. But the thing is more that 5 to 10 seconds is that advisable. More if it is do more than 10 seconds, if you take more than 10 seconds, it will cause affect, maybe the patients will go to hypoxia also. So that you have to keep it in mind. And the another thing is humidification, because when they usually we breathe through the nose. So our inside the nose there is a hairy hair, the things there, though that will filter out the dust and insects, so that all fresh air will go inside our that lungs. So here we directly open the trachea, and so that the patient breathe through the trachea, right? So there is a chance of dust entry, there is a chance of insects entry. So and also there is no humidification. The air is directly go to the trachea. There is a chance of dry cough. So what you can do is you can take a wet netted cloth, and that squeeze out the excess water and put it on the tracheostomy area, so that the patients will get the humidified air. And stoma protector is also you can use both that, for so that we can able to prevent insect entry and dust entry. And the next option is speech therapy. So here also you can they can speak 1 or 2 words they can speak, but you have to give a proper training. They can take a deep breath and close to the tracheostomy area, and then they can able to speak few words. So you have to train them. So these are the important things you have to keep it in mind while take care of a tracheostomy patient. Okay, so we have a video on that also. We can watch on that, and after that, if you have any doubts, please ask me, and or you can put your questions in the chat box. Okay, thank you. Any doubts? Any doubts?
Ma'am, actually one doubt. The patient always keep in supine position only, otherwise to change the position in left lateral or right lateral, ma'am.
We can do, no, supine position is not contraindicated. If they are able to lie down in supine position, you can put the patient in supine. No need to put the patient in right lateral or left lateral. This is the tracheostomy, no? No need.
One of my patients having the bed sore in the back side, ma'am. Always
Yeah,
I'm keeping
so,
the supine
yeah,
position,
then,
and the bed sore is not healed.
Yeah, for the pressure sore management and prevention, you can put the patient in right lateral or left lateral position, because we need to protect the sacrum. We need to relieve the pressure from the sacrum. So either you can put the patient is in right lateral or left lateral.
There is no problem, ma'am.
There is no problem, nothing.
Okay. Thank you. Thanks.
Okay. Do one thing, I think you can put the patient in semi-fowler's position and change it, so that that upper part of the chest will rise, no? So it will not affect the patient breathing part. So semi-fowler's position, just 30-degree elevation is enough. And then
Okay.
you can put the patient in either right lateral or left lateral.
Okay.
For ileostomy or ascending colostomy, is there any option like colostomy irrigation? No. So here, ascending colostomy, what is the type of fecal matter? The type of fecal matter in the ascending colostomy? It's a liquid only, liquid from the ileum. That directly the fecal matter will come to the ascending colon. So again, the fecal matter will be liquid. There is no need to irrigate that area because all the time within 2 hours after eating, the fecal matter will be coming into the ascending colon, right? So there is no need to irrigate because there is already fecal matter is liquid. No other option. And descending colostomy, at the end part of the descending colostomy, then you can think about that. Based depends upon the stool type, you can decide. So if you don't have any questions, we can move on to the case presentation.
Yes, ma'am.
Nandana Rai will be presenting a patient story. Nandana, are you there? Just Jesse, what is your question? Any food restriction or any good? You typed in good. Are you mean food? Yeah, okay. There is no food restriction. If they have any foul smell problem, then they can control onion, garlic, cabbage, these kind of foods. But there is no restriction, absolute restriction. If they have any problem, then they can they can control. So better they can use same oil for cooking so that we can able to prevent diarrhea. And always they have to maintain a hygienic practice. So that's it. Thank you. Nandana, are you there?
Hello, yes, ma'am.
Yeah.
Ma'am, can I start?
Yes, you can.
So, a very good afternoon to everyone. Today I'll be presenting a case on CA rectum. So, my patient detail is he was a 40-year-old male who was diagnosed with CA rectum. Coming to the presenting complaints, he came to the emergency department with a complaint of general body weakness, nausea and vomiting, slurring of speech, and constipation for a week. History of illness. Patient is a known case of chronic alcohol with CLD, that is, and patient was referred from community health center to district hospital with the complaint of slurring of speech, decreased appetite and generalized weakness, constipation for a week with abdominal distension and tenderness was also present. On examination, patient was conscious and oriented. There was abdominal distension and tenderness present. Vitals, temperature was 98, respiration was 22 breaths per minute, blood pressure was 120 by 90, pulse rate was 90 beats per minute, and SpO2 87 in room atmosphere. And coming to pain scale, the pain scale was moderate to severe and the pain score was 6. Treatment and significant investigation. Routine blood examination like hemoglobin, which was 9.1 gram per DL. Random blood sugar was 132.9. Albumin was 2.71 gram per DL, that was decreased. Alkaline phosphate was 164. Total protein was 6.27 and uric acid was 2. The CT scan was also done for the abdomen, where it was shown that there was malignant neoplasm of rectum with large bowel obstruction and also hepatic metastasis. And also the CT scan for the brain was done, but nothing abnormal was detected. And the treatment done was elective ileostomy. Now, coming to the psychosocial aspects, he was a 40-year-old patient, driver by profession, living with his wife and 3 children. His wife is a farmer. He and his wife are the breadwinner of this family. His kids are school-going children, and presently his wife is taking care of everything. He regrets being an alcoholic and is worried about the future of his kids and his wife, and also about the treatment regimen. He has lost his joy and confidence and has disturbed body image due to ileostomy. Coming to the medication that he got was, the first thing was proctolysis enema because he was having constipation. Then injection ceftriaxone 1 gram, that was given BD. Injection amikacin 500 mg, that was also given BD. Injection metrogyl 500 mg TDS. Injection diclofenac 75 mg BD. Injection PCM 1 gram BD. Injection Pantop 40 mg, that was given once. And injection ondansetron 4 mg thrice daily. And injection tramadol 50 mg with NS 100 ml, that was given SOS. Now, main concern was altered body image because of the ileostomy, pain, diet, financial problem, and treatment regimen. Coming to the summary, a 40-year-old patient from a low socioeconomic background diagnosed with CA rectum and has undergone elective ileostomy. Now, the discussion points are: do we need to provide palliative care for this patient? What are the problems faced by this patient, and what all can be done for his patient and his wife? Thank you.
Thank you, Nandana, for the wonderful patient story. It's
Thank you, ma'am.
the correct patient story today. So today we have discussed about ostomy care. Especially we had discussed about ileostomy care also today. I hope this presentation is clear to everyone. We can move on to the discussion points. Definitely, this patient need palliative care. Okay, without
Yes.
asking anyone, this patient need palliative care. So the next question is, what are the problems faced by these patients? And we go back to the main concern, main problems. Yes, these are the main concerns: altered body image, pain, diet, financial problem, and treatment regimen. So altered body image will be there. For that, what you can do is you have to, before doing a ileostomy, before procedure, we need to do a pre-operative counseling. So almost all the centers, this should done, because before that they should aware of that. So before after surgery, otherwise they will not be able to tolerate. So during the pre-operative counseling time, we usually tell the patient about the situation and what are the complication, what are the possibilities. These all things we used to tell, and if they agree, then we will think about the surgery. Here, this patient is having CA rectum and complete intestinal obstruction. There is no other way. So complete intestinal obstruction is also there. So that patient will develop vomiting, colicky pain, so many problems. The treatment, this is the only way to save this patient. So ileostomy is the best management for this patient. So that we need to tell them. So even then, the patients can develop these kind of emotions because we already discussed. When the bowel is moved, the fecal matter will come out. Smell will be there. So this will be affecting the patient emotionally. And no, sometimes they are not able to fix the pant as usual. And sometimes they are not able to fix the waist that thing and the waist level. So these kind of things will be affecting the patient emotionally. Definitely will be there, but the thing is, you have to listen. Why they are that altered image, body image is one of the major part, but we have to listen. That is there any problem? We have to understand his emotions. Is there any problem, Nandana?
Ma'am, problem?
Yeah. So why this altered body image is one of the major problem here, right?
Yes, ma'am.
Did he express anything?
Ma'am, actually, he felt shy to go about with the ileostomy bag. He thought that his friends would come meet him and
So that is inside the body, so they usually wear shirts and uh,
ma'am, but the smell.
so
He was
smell,
mainly
yeah, smell,
yes, ma'am.
yeah, smell
And
is the
also,
first.
he's a driver by profession, so
Yeah.
that was his main concern, ma'am.
Yeah. So here, altered body image because the externally it will not be visible. So we
Yes,
can
ma'am.
able to cover it. Okay. So
Yes, ma'am.
and the thing is, he is not able to continue his works. That is one of the major part. That will be affecting this patient emotionally, and also the fecal matter smell, the smell of the fecal matter. So if there is a smell is the main problem, then you can do the assessment about the diet pattern. So what are things he used to eat? If he used to eat cabbage, garlic, onion, these kind of things, you can tell them to control these kind of foods. Nandana, do you want to add anything? Anything you want to?
No, ma'am.
No. So anybody else want to add anything? This patient is having altered body image. So altered body image, anyway, the emotions will be, the emotional problem will be there all the times. But the thing is, we can able to cover from the external people. But the foul smell, the fecal matter smell, we can't prevent. When the fecal matter will come out, definitely the smell will be there. So that will be affecting the patient emotional because other persons will be
Here,
um,
anxiety.
anxiety will be there, sure, and the others will be maybe giving some maybe a familiar facial expression. If there is some smell coming out from the stomach, this will be affecting the patient emotionally. Definitely, I have seen many patients like this. So this is the major problem. So when the bowel is moved, the fecal matter will come out, and along with that, some gases also will come out. No, that will be affecting the
Yes,
spreading
ma'am.
into the room, and so that all persons will be seeing towards the patients, and then it will create another problem. So anxiety is also, they will be anxious. So that is one of the major problem here. What you can do is you can ask about the that diet pattern. So, and you can tell them to give advice some change of diet. And for
Okay.
what about pain? Where is the pain? And pain is controlled or not?
Ma'am, after the medication, the pain was controlled.
Okay, now there is no pain free, right?
Yes, ma'am.
Okay. Definitely diet pattern, you have to tell them. We already discussed financial problem. Three childrens, they are studying. Definitely
Yes, ma'am.
he needs support. Now his wife is the breadwinner. What you can do is you can that connect this patient with the palliative care support team if you have. Definitely through that they will try to support their studies. So in palliative care, we definitely we will look into the four aspects, and if they have a come into the rehabilitation part, if they have a physical problem, then we will think about physical rehabilitation. If they have any any income income development, then for that we will think about the vocational rehabilitation. If the students are not able to continue their studies, if their children's not able to continue their studies due to their parents' illness, then we will try to support their that studies also, like educational rehabilitation. So you can maybe you can connect with the good palliative care team if you have, so that they will help, they will support them. And treatment regimen, definitely you need a teamwork. You need to talk to the patient. You have to talk to the doctor. You give a proper nursing care. If they have psychosocial issues there, if you have a social worker there, try to include the social worker in the care. If you have a psychologist in your care, you can try to include a psychologist in that patient care, so that the psychologist will listen and give some counseling also. So the altered body image is one of the most major problem here. So he needs counseling. So at least if you don't have any psychologist or medical social worker, if you have any time, you please go there and sit down and listen his emotion, so that all problems will share with you, so that you will get an idea, and based on that you can support.
Yes, ma'am.
Anybody else want to add anything? Any points? Any suggestions? Anybody? Time up. So this is one of the good patient story for today's session. Anyway, we discussed a lot today. Today we have learned about colostomy care, colostomy irrigation, and tracheostomy care. Always you have to keep it in mind, the important points. Uh, Please try to help the patient and family. If you have any doubts, please call me. I will be able to help you. Thank you.
Thank you, ma'am. Thank you for the wonderful presentation. Thank you, Nandana Rai, for wonderful the case presentation. Thank you
Thank
all
you,
for
sir. Thank you, ma'am.
thank you all for participating actively in the sessions. Thank you. Let's see in the next session. Bye.
Thank you so much.